time, you can have a PC rent any time during FACO, during IA, during IOL insertion, and even during AC reformation also. Sometimes the PC can open because a very weak PC. So things are very stable now. And lastly, you can gently place in a IOL. So don't try to exert too much pressure on the posterior capsule, and just you can place a foldable IOL in the back. So surgery is over. This is actually an unedited video. So you just follow the basic principles. Next video. So this is a posterior polar in a soft cataract. Next one, video 2. So this is posterior polar in a hard cataract. Play panel. Okay. So little hard nucleus is quite difficult because chopping will be quite difficult. So it's the same basic principle, never hydrodissect or dilute. But again here the second instrument has a major role, because you'll say once one quadrant of the nucleus is removed, the quadrant under the incision is very difficult to maneuver. So either don't use a chopper, go back to a dialer and try to just disengage that nucleus. Somehow it will start moving around. So just hold on. So don't change much your setting, whichever you do routine phaco, you can do it. So this sub incisional nuclear fragment is the one which is difficult to remove it. So always do all the maneuvers very gently. So once a small fragment is there or sub epinuclear plate is there, you can just leave it on. Again, the same basic principle has to be followed. Go inject sodium iodide into the anterior chamber, into the bag, and come out. So never allow the capsular bag to get decompressed. So once the IA is over, so you don't have to really bother about the hydrodissection. So most of the phacos, even without hydrodissection, you can proceed, because by the time you just do a chop and start do your maneuver, so it's the same principle. The two principles has to be followed when you're doing posterior polar cataract. Keep always deepening the anterior chamber and the capsular bag. So everything is under control. Third. So this is. So this is the most challenging case now. Posterior polar, posterior capsular dehiscence. The posterior capsule is already opened. So now the challenge, what to do? Whether you want to do a SICS or a phaco. Play பண்ணுங்க. இல்லையா ப்ளே ஆகல. இல்லையே இங்கே ஒன்றும் மூவ் ஆகலையே. க்ளோஸ் பண்ணி ஓப்பன் பண்ணுங்க. Okay. Now you can see when I decided to do a phaco in this case. You can see the posterior capsule opened under the nucleus, but still I go ahead with the phaco. The only thing is that posterior capsule dehiscence has been there for a long time, so probably the anterior vitreous is already absorbed there, and so lucky I didn't have any drop or PC didn't extend. So again the same maneuvers are followed there. So the settings and all the same settings routinely which you use, so that the anterior chamber is always deep, no collapse. So all the maneuvers are very gently done. So you can see a large capsular opening behind the nucleus. So now again the same basic step is being followed now. Just before removing the phaco probe, I inject sodium hyaluronic into the bag. So, now once the things are very stable, no vitreous, so I could able to place a IOL in the back. So the basic principles of PPC are never allow the eye to get decompressed. So unlikely to have a PC rent. Thank you.
Thanks for and videos and basic principles have been given. Now let me invite Dr. Lahani, a national leader at the level of AOS and an excellent.
Thank you, Jason sir, and thank you very much, the Kerala Ophthalmic Society, Srini, and all the President, Secretary of the Kerala Ophthalmic Society. So this is about the suprahard cataract. So there is no any financial interest. So what happens when you are doing it? It is difficult to break, and the zonules are loose because it is a nuclear cataract. And once you are using more energy, then there is a endothelial damage. Then how to manage? So you will have to manage with you yourself and the setting of the machine. So you can use the high vacuum when you are using that. Then IOP, you can, if you can maintain in the machine, you can maintain the IOP, and you should use here the adequate power for this. And you can also use the cohesive and dispersive visco to protect the endothelium. It is called the cell. Then you can, this is just what I do: quadrant removal, pulse mode, direct chop. You can go for the continuous with high vacuum and trenching, multiple burst and burst mode if it is there in the phaco. Now how do we manage? So as it is, it is an hard cataract. Then there are a capsule is not seen, glow is not seen, weak zonules, the endothelium going to get damaged, and then the trenching is difficult, and the PCR risk is always there in our backup mind. So you can have a dye-assisted rexis, then the so the rexis can be done by the dye, and here whenever you are doing the rexis, so rexis should be slightly larger. Otherwise, the nucleus is very bulky, and when you are doing in the small rexis, then you don't know what has happened. But sometimes the PC is tiered as the accommodation, that means the area which was less, and that tears the posterior capsule. So it is always better to have slightly larger rexis. Then the phacopower modulation is very important. See the cataract, you can see the patients. Can you see here? It is a, always there is, if there is a white element inside, then in such situation, yes, you can use the direct chop. Here you can see the posterior fibers are very important. So whenever you are chopping, in the chopping you will have to use the, see here, separation till the center. Once you separate it, see here the posterior fibers, and those posterior fibers, if we are able to separate, then there is no problem. Or otherwise, what happens once you are lifting the piece, that the posterior piece which is adhered to your one piece. So whenever you know that this piece is complete